We might get started with some housekeeping while we let people trickle in. So, as people are joining, I will just welcome you all to the DARIA series, the Drug and Alcohol Research and Innovation Active Learning Network. DARIA is a virtual weekly seminar program delivered by St. Vincent's Hospital Sydney Alcohol and Drug Service and the National Centre for Clinical Research on Emerging Drugs, NCCRED, in collaboration with Southern New South Wales Local Health District, Murrumbidgee Local Health District, Far West New South Wales Local Health District, and Western New South Wales Local Health District. The aim of the series is to promote innovative practice and share learnings and new ideas amongst clinicians and clinical researchers working in the field of methamphetamine, emerging drugs, and other areas of alcohol and drug health. So I would like to start today by acknowledging and paying respects to the traditional custodians of the lands and waters of Australia and all of First Nations elders past, present, and emerging, especially those joining us today. And I know that there are some emerging leaders on this call today. We respectfully acknowledge the traditional custodians of the land and waters, their contributing cultural, spiritual customs and practices. I'd like to welcome our speaker for this week's DARIA session. Dr. Jamie Berry is a clinical neuropsychologist and director of the group private practice Advanced Neuropsychological Treatment Services, ANTS. Dr. Berry is a clinical associate professor in the Faculty of Medicine, Health, and Human Science at Macquarie University. Jamie's current research focus is the assessment and remediation of cognitive impairment amongst individuals with substance use disorders. He is the project lead of the ACE project, a collaboration between ANTS, the New South Wales Health Agency for Clinical Innovation, and WHO's We Help Ourselves. Also, before we get started, please remember that there will be a recording available after this session. It's freely available and ready for you to share with your colleagues, with your peers, or with any consumer or client that you feel might be interested. You'll find the recording for today and all of the previous recordings or future recordings should you miss a session on the NCCRED website. And just a tiny bit of housekeeping, next week's presentation of the DARIA series will actually be cancelled due to the public holiday in New South Wales. So without further ado, I will hand over to Dr. Jamie Berry. Thank you so much for joining us today, Jamie, and I will pass it over.
Thanks a lot, Krista, for the introduction. I'm going to do my best to get through quite a lot of material today. And before I start, I'd like to acknowledge the very hard work that has gone into developing the ACE resources by a very large number of people, too many to mention here. But as Krista alluded to, this is the result of a partnership between the Agency for Clinical Innovation, ANTS, and WHO's. And we had many other stakeholders involved, including academics from the University of Wollongong, the University of Newcastle, NDARC, and so on. And they're all credited in the official resources of the ACE program. So if you haven't heard about the ACE program, you could pretty much find out everything you need to know about it by going to this website here, aci.health.newsouthwales.gov.au/projects/ACE-program. Now, the first time you go to that site, you will be asked to register in order to keep up to date. So you just need to enter your name, email address, which sector you work for, which local health district, if you work for a local health district, and whether you're mainly interested in the tools for clinical use, research, or both. And that's a one-time registration. And that's important in terms of keeping abreast of any updates we make to the materials, which we are actually going to make imminently. Now, the ACE resources include 4 major chunks. The first is the ACE screening tool. The second is the ACE Brief Executive Function Assessment tool. The third is the ACE Brief Intervention. And finally, there's a 12-session cognitive remediation program, which we will also be publishing an Aboriginal and Torres Strait Islander supplement for in the very near future. So I'm going to briefly speak to each of these 4 resources. The ACE screening tool is the simplest of these resources, and as the name suggests, this tool was developed to screen for risk of cognitive impairment amongst people with substance use disorders. So from a larger set of items, we distilled it down to 12 items that take less than 2 minutes to administer. The items are simple questions that require a yes or no response. And the scoring is simple. It's simply adding up yes responses across the 12 items. And this is what the screening tool looks like. They're the 12 questions. And again, if you register on the ACE website, you'll have access to that tool, which you can use free of charge as many times as you like. We published a paper in Applied Neuropsychology last year outlining the psychometric properties of this screening tool and some validations. So we were very pleased that we ended up with a very high test-retest reliability of 0.97. For the uninitiated in psychometrics, that means the tool is likely to give you the same result when you administer it on separate occasions. We also established construct validity in that the ACE screening tool is related to standardized measures of cognitive functioning. So we've got the correlation coefficients there of how strong the relationship is with the MOCA, the Brief A, the TOPF, and the 5-point test. So respectively, a cognitive screening test in the MOCA, a self-report questionnaire about executive functioning in the Brief A, TOPF, an overall estimate of intelligence or IQ, and the 5-point test is a design fluency task. We also established criterion-related validity. So we demonstrated that the ACE screening tool was related to a variable that classified individuals as being intact, having some impairment, or being impaired. And the way that we allocated people to those three groups is they were intact if they scored within normal limits on both the MOCA and the Brief A. They were classified as being impaired if they came up in the impaired range on both the MOCA and the Brief A. And they were put into the some impairment group if they had impairment on one of those two measures. And as you can see here, the average scores on the ACE screening tool, so these are scores out of 12, differed significantly, with an average score of 1.2 for the intact group, 2.8 for the some impairment group, and 5.3 for the impaired group. We also looked at classification statistics, and we recommend a cut score of greater than 2 out of 12 as being indicative of a risk of cognitive impairment. And we chose that cut score because it was associated with more than 95% sensitivity. So we were aiming for a tool that would identify the majority of people with cognitive impairment, even if specificity was low, meaning the tool is also going to include some people who don't have cognitive impairment. But as a first-line screening tool, it's desirable to have higher sensitivity than specificity. But we have published this table in the article, which allows clinicians to set their own levels of sensitivity and specificity depending on the purpose for which you aim to use the tool. So in summary, the ACE screening tool has demonstrated excellent reliability, construct validity, and criterion validity. And with a cut score of greater than 2, it has excellent sensitivity and negative predictive power, meaning it's likely to detect cognitive impairment when it is present. And we therefore recommend the ACE screening tool as a first-line screener to screen for cognitive impairment within substance use disorder services. Now, it should be said that we validated this tool amongst people in residential SUD treatment. We are currently working on a paper that describes how the tool functions in an outpatient setting. So that's the the ACE resource with the lower bar of entry for services and clinicians. It's free of charge and it doesn't cost very much in terms of time to administer. The next level up is what we call the Brief Executive Function Assessment Tool, or the BEAT. And the goal with development of the BEAT was to develop a cognitive screening test specifically in order to detect cognitive impairment in people with substance use disorders. Many clinicians and researchers use existing tools to screen for cognitive impairment, such as the MoCA. And whilst the MoCA has been validated to be a valid test in people with substance use disorders, it was initially developed to detect dementia or mild cognitive impairment due to progressive brain illness in people at an older age than is the typical age of people receiving substance use treatment. And so we wanted to focus on the particular profile of cognitive impairment that's associated with SUD sample. So we undertook several validation studies and several iterations of the BEAT before we landed on this final one that we've published. The BEAT takes 20 minutes to administer through an experienced examiner. If you're starting out using the BEAT, it may take you closer to 30 minutes to administer the test. We strongly recommend that if you are going to administer the BEAT, that you at least undertake the online training that's available at the website I mentioned earlier, and or additional training to ensure fidelity of the outcomes. After you've administered the BEAT, you get a score that places the person in the intact, mildly impaired, or severely impaired range of cognitive functioning. The BEAT has many items that you would be familiar with from other assessment tools, such as the MoCA. For example, it's got a trail making item, it's got a clock drawing item, it's got a figure copying item. So these are fairly stock standard elements of a cognitive screening tool. But there are some unique items that aren't found in other screening tools, such as motor series. So this is the Luria motor series. Luria developed this test specifically to detect impairments in frontal lobe functioning. And we found that it's quite sensitive within the BEAT. We've also added a delayed discounting item. Delayed discounting is commonly used in the drug and alcohol experimental literature. So we've adapted that task for this clinical tool. And importantly, there's also a prospective memory measure, which to our knowledge isn't present in any comparable screening tool. And we thought this was an important innovation and improvement on other tools, because often people with substance use disorders, whilst their episodic memory may be intact to mildly impaired, it's prospective memory that they tend to ecologically struggle with the most. So prospective memory is remembering to do things in the future, such as, I must remember to get milk on the way home. We have also importantly added a visual memory test. The MoCA, the Mini Mental Status Examination. In fact, many cognitive screeners only include tests of verbal memory, but the drug and alcohol literature, particularly the alcohol literature, shows that visual memory actually tends to be more severely impaired amongst people with long-term alcohol use disorders. So we've got a visual memory item. We've also got an incidental learning item, and that's a very sensitive item. Incidental learning is where you're not instructed to try to remember the information in the future. It's kind of just sprung on you. And so it may be better able to capture ecological memory disorder, because when people go through life, they don't necessarily effortfully try to remember every bit of information they come across. The beat also contains a questionnaire. In fact, the questionnaire is the first item. And whilst this is unusual in a screening measure and may pollute the overall performance-based nature of the tool with self-report elements, we felt that the self-report element was important because people with substance use disorders certainly tend to report day-to-day problems with executive functioning, and we felt it was important to capture that at least with one item on the beat. We've also included a reading test, which is, again, not very common in screening tools, but reading correlates very highly with overall cognition or IQ, and that's why it's in there. And we've also added 2 items. I won't go into detail in this brief presentation, but both of these items, AS minus WM and LF minus CF, are what we call process measures. So they're items that are made up of subtracting one item from the other. For example, AS minus WM stands for attention span minus working memory. And we found that that item, as well as letter fluency minus category fluency, can really highlight issues with executive functioning. There are 3 parts to the beat, so it's not as straightforward as the MOCA, for example, that is all contained on one single sheet of paper. Part of the reason for this is we wanted fidelity of instructions, so all of the instructions are included verbatim on the beat form. So specifically on the record form, and this is the form that the examiner uses to record examinee responses. There's also a response form, and this is for the examinee to complete elements of the beat themselves, such as the trail making, the clock drawing, and the figure copying elements. And then there's a stimulus card. That's a single sheet that contains the stimuli for the reading and naming tasks. So we have also published a paper on this, looking at the psychometric properties and validating the beat. In terms of internal consistency, we got a Cronbach's alpha of 0.73, which is adequate. So above 0.7 it is adequate internal consistency. Having said that, we have included quite a diverse range of tasks that all fit under the umbrella of executive functioning. But executive functioning is such a multifaceted construct that it's not surprising that there isn't an enormous amount of consistency across the items. The test-retest reliability was encouragingly quite good at 0.85. So again, this means that if you get a result with one individual on one occasion, you're likely to get a similar result on the second occasion of testing. And inter-rater reliability was almost perfect at 0.99, meaning if 2 people assessed the same individual, they're highly likely to get exactly the same score on the beat. And we also established construct validity. So we showed that the beat was related to standardized measures of cognition, including the Stroop test, the 5-point test, the alpha span test, and the brief A, all with fairly high correlation coefficients, all of them being significant. Further, we established criterion validity in that the beat was significantly related to a similar variable as I described earlier, an intact sum impairment versus impaired ternary variable. And if we look at the scores here, the intact group scores an average of 32.5, the sum impairment group 27.7, and the severe impairment group an average of 22.3, and they were all statistically significantly different from one another. So we've shown that the beat is able to sensitively detect level of impairment. In terms of the classification statistics, we recommend that a score of less than or equal to 30 is the basic cut score. This is out of a total score of 60, right? So basically a 50% cut score. And that's associated with a 5% false negative rate, right? So in other words, 95% sensitivity. And then in order to determine whether or not someone has mild or severe impairment, if they also score less than or equal to 16, which is associated with a 5% false positive rate or 95% specificity, we would say they have severe impairment. So these are the cut scores that we recommend in the paper. Now, in terms of screening, we recommend a two-step pathway. The first step is to administer the ACE screening tool. And then if the person screens positive, in other words, the ACE screening tool is saying this person's at risk of cognitive impairment, then going ahead with a beat assessment. And we had a sample of 499 people with substance use disorder. And the pathway suggested that about 3/4 of them will screen positive on the ACE screening tool, and about half of the entire sample, 46%, will also screen positive on the beat. So this relates to the first row in the table. Yes, impaired on the ACE screening tool, and yes, impaired on the beat. That classifies 46% of the SUD sample as having an impairment. That's probably worth at least being aware of and or compensating for and or offering further neuropsych assessment or intervention for. And that only classified 1% of our healthy controls. So we had a healthy control sample of 139, only 8% screened positive on the ACE screening tool, and only 1.4% of the total sample also screened positive on the beat. So we're not getting too many false positives when we use this approach. So in summary, the 20-item beat was developed for the purposes of detecting cognitive impairment, and particularly executive functioning impairment in an SUD population. We've shown that it demonstrates internal consistency, test-retest reliability, inter-rater reliability, known groups validity. So that refers to the fact that a substance use sample scores a lot lower than a healthy control sample. We've demonstrated criterion validity, good classification statistics, and construct validity. And in addition to that, when using this two-step screening process, we've demonstrated incremental validity with excellent classification statistics. I haven't put the results up, but and it's because we haven't specifically published these results, but we get 99% negative predictive power when we combine those two tools. So moving along now, I'll discuss the ACE brief intervention. So the evolution of this component of the tools arose from discussions about, okay, we're developing some screening tools which are well needed to fill a gap in practice and in the literature. What do we do when someone screens positive? It would be almost unethical if we said, well, you just know that fact and you don't do anything else. So we thought, because we're working mostly with residential treatment services, we thought we would trial a single 1-hour group session as the briefest form of intervention that we could offer. And so what that intervention comprised was handing out a fact sheet that included the following sections. What is cognitive impairment? How might having a cognitive impairment impact my treatment, as in my substance use treatment? What causes cognitive impairment? Could I have cognitive impairment? and what can I do about it? And the what can I do about it then led to another resource that we developed, which was a tips and strategies sheet with 22 attention strategies, 10 memory strategies, and 14 executive function or higher level thinking skills strategies. And so I facilitated the group. I basically talked through the fact sheet to structure the group content. And at the end of the 1 hour group session, the intervention group, and this is the design of the study, so we randomly allocated 27 people to the psychoeducation group, 23 to treatment as usual. And these were all residents of WHO's. And after the group session, we asked participants to rate past and intended future strategy use. So out of those 44 strategies, how many they happened to have used in the past and how many they intended to use in the future. The treatment as usual group just got treatment as usual at this stage. Then 5 weeks later, we asked the same participants in each group to rate past and future intended strategy use. And so it was a fairly simple design where we compared past and intended future strategy use across the groups. Our hypothesis was obviously that the group that had received the psychoeducation would probably intend to use more strategies. We also looked at this follow-up period after 5 weeks, how much strategy use had in fact occurred over the past week across the groups. So this was baseline strategy use for the control group, blue bars, and the psychoeducation group, orange bars. So there was no difference in past strategy use between the groups. But after undertaking the psychoeducation session, the psychoeducation group had more intention to use strategies in the future, or rather had intention to use more strategies in the future. Then at the 5-week follow-up, we saw a significant difference in strategy use, so actual self-reported strategy use in the past week, with the psychoeducation group using, on average, 4 more strategies than the control group. So we felt this sufficiently validated the brief intervention for any services that wanted to proactively do something with or for their clients after identifying cognitive impairment. So we're halfway through the presentation, and the last component that I'd like to discuss with you is the lengthier one, and that's the ACE Cognitive Remediation Program. Incidentally, if you've got any questions, I intend to make some time at the end to answer them and or facilitate a discussion about any of the material today. So the ACE Cognitive Remediation Program was designed as a fairly intensive intervention to address the commonly reported and documented executive function difficulties experienced by people with substance use disorders. So there's ample evidence in the scientific literature that on average, people with a substance use disorder will experience at least mild, if not mild to moderate cognitive difficulties, and that mostly affects the area of executive functioning. Executive functioning includes any and all of these and probably some more. So difficulties with abstraction, impulse control, planning and organisation, sequencing, apathy, lack of drive, disinhibition, variable motivation, difficulties controlling aggressive impulses, a lack of concern, perseveration and cognitive inflexibility, distractibility, and so on. So the goal with developing this program was to provide easy to follow factual material about how the brain works. In addition to that, it was to provide simple tools and strategies and techniques to optimize executive functioning. Now, we took a leaf from the acquired brain injury literature in that most of the evidence points towards strategy training being more effective than drill practice training. So we weren't interested in plonking people in front of computer screens and having them do repetitive brain training exercise per se. We were more interested in imparting, modelling and teaching strategies and skills to help strengthen everyday executive functioning. So the program has very much an ecological orientation or focus. Incidentally, we did do some piloting back in 2016 where we actually asked the question, what are the relative improvements across two groups? One who just gets strategy training and the other that just gets computerized cognitive training. And overwhelmingly on the ecological measures, on the functional executive functioning measures, there was a far superior gain from doing the strategy training. And so we decided not to have any computerized cognitive training involved in the final version of the ACE cognitive remediation program. The techniques and tools in this program come from the evidence-based literature for both acquired and non-acquired brain conditions. And I won't go through all of them. The program comprises 12 sessions. The way we evaluated it was at the intensity of 2 sessions per week. So the full program took 6 weeks to complete. Those are the names of the 12 modules. So basic introduction. And then we decided to put learning and memory and attention right up the front because obviously a person would benefit from applying attentional and learning and memory strategies for the remainder of the program. So modules 2 and 3 are a little content rich and we provide lots and lots of strategies and techniques to enhance memory and attention early on, but we do encourage the participants to revisit those throughout the program just to ensure that they're using them appropriately. Then there are a couple of sessions that sort of introduce the concept of executive functioning, so one on goals and planning and another one on time horizons and the executive team. And then the next 6 sessions focus on the 6 elements of Russell Barclay's model, evolutionary model of executive functioning. So self-reflection, inhibition, visual working memory, verbal working memory, emotion regulation, and problem solving. And then there's a final revision module. So these are the what we call the executive team, again reflecting the 6 elements of Russell Barclay's evolutionary theory. In theory, these evolve in this order so that they not only evolve, but they come up developmentally in this order. So self-reflection or self-awareness is the first executive function to develop in childhood. Then comes inhibition, then visual working memory, then verbal working memory, then emotion regulation, getting into adolescence. And the player represents problem solving and decision making, which are the more mature executive functions. There are a couple of models that go throughout the program. The first is the triune brain model, and although in scientific circles this quite rightly gets some criticism, we included it because it's an intuitive model, and in fact the feedback we've received both formally and anecdotally from participants was this makes a lot of sense. And so we're using the model more for utilitarian purposes than for scientific integrity purposes. And the three parts of the brain obviously are the reptilian brain, which focuses just on the present, right? It asks the question, what should I do based on what's happening right now? And so participants are encouraged to reflect on, the lives of reptiles and their day-to-day concerns. And it's mostly what's going on right now and how can I get there? Then there's the limbic system, which is the next layer of brain to have evolved. And this asks the question, what should I do based on what's happening right now, as well as what's happened in the past? So mammals, the limbic system's the paleomammalian brain. And so we ask participants to reflect on, mammals' capacity for cognition, and most people would agree mammals can remember. If you feed a stray dog, it's going to remember where to come to get the food next time. And so this codes very basic memories, episodic memories. And, well, I shouldn't say episodic memories. I think it's false to say animals have episodic memory, but let's say associative and operant-based memories. And then there's the rest of the cortex, of which a third of it is made up by the frontal lobe, which we refer to in this program as the future lobe. And it's called the future lobe because it asks the question, what should I do based on what's happening right now, on what's happened in the past, as well as, importantly, what I want in the future. And so being a program designed to enhance or optimize executive functioning, there's a huge emphasis on future-oriented thinking and behaviour. We speak about executive functioning as that part of the brain, that part of cognition that allows you to process what should I do next or in the future based on what I already know. And so this is another model that's introduced in Module 1, in fact. It's a very basic representation of the brain with the various lobes. And we say if you split the brain in that way, so you've got the front part and then the back part, we give some basic orientation to the fact that the back part contains all of the primary sensory cortices, so vision's processed in the occipital lobes, sound in the superior temporal gyrus, and the parietal lobe processes sensory information. And of course, temporal lobes contain the hippocampus, which is involved in encoding and storage of memories from the past. And so the back of the brain specialises in answering the questions, what's happening right now and what's happened in the past. And that information is transferred via a superhighway to the frontal lobes to answer the simple question, well, what should I do with all of that? Or what should I do next? Because it's concerned with what should I do next, it's focusing on the future. So Talia Nardo, one of my PhD students, has very systematically and comprehensively evaluated the ACE cognitive remediation program. We had 527 participants. These were residents of substance use treatment facilities in New South Wales. We had 10 facilities participate in the study. 255 of them participated in some cognitive remediation, and 214 of the participants had pre and post data. Now, I'm not going to present to you the results of the stepped wedge design, which is what Talia looked at in her PhD. I'm going to present you the per protocol analysis. only because Talia hasn't yet published her work, but intends to do so very soon. So we had mostly males, mean age of 36, mean education level of 11 years, and 14% of our participants were Aboriginal and Torres Strait Islander people. Methamphetamine, the blue, and alcohol, the orange, were the largest primary substances of use. And so just in terms of the design, over an approximately 8-month period, every 6 to 8 weeks, the participants were tested on the same battery of tests. And in that 6-week intervening period, they either had cognitive remediation or they had treatment as usual. And so we compared the groups on that basis. And so the basic result is, well, let me first orient you to this variable. The primary outcome measure we went with was the Global Executive Composite Score of the Brief A, which is the Behaviour Rating Inventory of Executive Functions for adults. So this is a 75-item self-report questionnaire about everyday executive functions. Prior to cognitive remediation, or at baseline, about 53% of the sample had at least mild impairment on the Brief A, right? So more than half. And this is the proportion who had moderate impairment, and this is the proportion who had severe impairment. And comparing that to our healthy controls, less than 10% of the healthy controls had mild impairment on the Brief A. So that there is what I think most clinicians are aware of in terms of the difficulties that this population experiences with everyday executive functions. So after undertaking cognitive remediation, or rather after undertaking 12 sessions, so the full program, the level of executive dysfunction went from 53% down to 27%. So it was essentially halved. It obviously didn't get quite to the healthy control level, but I think that would be unrealistic. We did a post hoc analysis essentially looking at a dose effect, or looking for a dose effect. We found that, so on the Brief A, the scale is follows a T-score distribution, so a mean of 50 and a standard deviation of 10. And so the treatment as usual group improved by 3 points, which is about a third of a standard deviation. And we would expect that because, of course, being in treatment means usually you're not continuing to use drugs or alcohol, and you might be learning some good skills. So that was the treatment as usual effect, about a third of the standard deviation on our primary measure. We looked at partial cognitive remediation completion. So this includes all people who had anywhere between 1 and 11 sessions of the 12-session program, and they basically doubled the gains of the treatment as usual group. And for those that attended all 12 sessions, they basically trebled the gains of the treatment as usual group. So we've got good evidence that this program results in improved executive functioning. We also looked at program completion, and the treatment as usual group had a 34% program completion rate. So this is completing the drug and alcohol treatment program. And we didn't quite double it, but we had 63% program completion for those who also attended cognitive remediation during their program. The odds of completing the program in a facility that had adopted cognitive remediation was almost twice as, 2.5 times higher than if they were in a treatment as usual facility. So I'm pleased I got through all of that material with about 12 minutes left to take any questions, which I'm happy to do. Before I open it up for questions. I've made my slides available. Again, there's the website. And if you like, I'm happy to give you a quick orientation of the website and what it looks like, but it contains more than just the manuals and the materials. It also includes some videos. There's a getting started video that goes for 12 minutes. And then for the cognitive remediation program, there's a brief 1 or 2 minute video that introduces each module. And that's helpful for people who facilitate the program to just get a basic orientation of what's involved in each module. And freely available is also the PowerPoint presentations that are used to guide the intervention. So I'll stop talking there and open it up for any questions we might have.
Thank you so much, Jamie. How interesting. And I love how you stepped it all out and got us somewhere where we can actually offer something to participants and patients. So one of the questions that I had right off the bat was, have you done any investigations into what patients think about this program or about the testing? In my experience, patients really want to know. They want to be able to have some sort of clear sort of picture of where their neurocognition is and how that compares. Is there any feedback that your studies have given you around that?
So we very deliberately sought feedback on the brief intervention and the cognitive remediation program, and that was overwhelmingly positive. So people reported benefiting a lot, learning a lot about how their brain works, learning to use different strategies. So that feedback was positive. With respect to the testing, we did have some very constructive feedback early on, and there were some parts of that we did end up changing, either because of the difficulty level or the framing wasn't quite right. In the manual for the beat, so this is the examiner manual, there's a blurb that is suggested to give to participants before you undertake the test with them, so that they're not left with any misapprehensions about why the testing is being done. And it's a very person-centred blurb, something to the effect of, we'd like to examine how your thinking skills are, because often people in substance use treatment may have difficulties with memory and thinking. And if that's the case for you, we want to know that so that we can adapt our program to better suit your needs so you can get more out of it. So as long as the framing and the rationale are person-centred, I haven't heard any negative or adverse feedback from participants themselves.
And I guess because then you go on to offer an actual modules that can actually improve the situation. So I guess that probably, to my mind, that would probably improve your uptake right there, because you're not offering sort of bad news without packaging it with some sort of way of improving on that. So that's probably, I don't know. Then I guess the other question that I had was around the actual screening tool or the beat. With either of those, I know that you flashed the screening tool up really quickly, but I didn't have a chance to get in there and read through quick. But is there any risk of a practice effect with either of the tools? Is there any kind of...
Yeah. So there is a practice effect with the beat, but we've published what that practice effect is. And so that can be taken into account for reliable change analyses. And so we've provided all the material needed to do those calculations. Interestingly, the practice effect was less for our clinical group. It was more for our clinical group than it was for our healthy controls, which is opposite to what you normally see. But we thought that, on reflection, we thought that must be the case because people do improve in their cognition when they're in residential treatment. So, we would expect them to improve more than healthy controls. With the ACE screening tool, there was little to no practice effect. So that doesn't need to be incorporated. You wouldn't expect a practice effect, of course, because the questions are historical questions such as, have you ever been hit on the head and lost consciousness? have you ever had a drug overdose, and so on. So unless someone's had one of those things in the intervening period, we don't expect them to score any better or worse, if you like.
Right, of course. And so with this program, we've got a question from, I think it's Sarah Adams on the line. We've got a question asking if the cognitive remediation program has been adapted for use in the community, so outside of a resi rehab program or that kind of structured program.
So we're in the final stages of finalising what we're calling the ACE Flex program. And that would be the response to that question from Sarah. So yes, there will be a version of it available outside of the resi setting. And well, we've developed it for both the resi setting and other settings, in that the way we've evaluated the program to date is in closed groups. So you had to be at module 1 to complete the program, and you had to do the 12 modules, or at least be willing to do the 12 modules. But of course, with resi programs, and more so with outpatient services, you might get a scenario where people are going to come 1 week, have 2 weeks off, come again. And so we've developed the ACE Flex to be implementable in a sort of open group format. So you don't have to do the modules in order.
That was going to be my next question. That was
Yeah.
so with the current program, you have to do them chronologically. They build on each other, because I noticed that you mentioned that the first couple are quite information dense, and start with loading some tricks and tips. So that one does need to be done 1 through 12 sequentially.
Correct.
But you're saying that the Flex will give us an option whereby people can pop in and out and pick up at chapter 4, having done 11 and 12 previously.
That's right. That's right.
Excellent.
So it's obviously a lot more flexible. That's what the sector wanted. So that's what we're about to deliver.
Excellent. And so just before I can carry on with my questions, I'm just going to remind everyone that if you want to unmute yourself or join the discussion, please feel free, raise hand. Rob Page has asked something here. What is he saying? Really interesting. Thanks. He does have a question. Apologies if it was mentioned and missed. Has there been, or will there be, a longitudinal follow-up for those people who underwent the ACE cognitive remediation to see whether the learnings stick? So I guess that's outside of your I think it was 6-week follow-up that you did?
Yeah, we actually do have those data, and Talia will be publishing those data. So we continued to follow up people if they were willing to still be involved in the research, even after they were discharged from the service. So we do have some follow-up data, but it probably only goes for about 3 months at most. I agree that it would be a good idea to do a much longer term follow-up, say around a year, to see whether those learnings actually do stick. Sort of related to that question, we did, just because of the design of the study, there were some participants who undertook the program several times because they might have been in rehab for more than 1 cycle of the program. And anecdotally, we received feedback from some participants that the program made a lot more sense for them the second time around, and they were able to adopt more strategies. So there's probably no harm in doubling up. I know that that's a sort of tangent to the question, but I think obviously if you're dealing with a population that experiences mild to moderate cognitive impairment, there's no harm in repeating the material. And I'd be interested to know whether, if we do the long-term follow-up study, whether going over the material a couple of times might help the information stick even better.
And in terms of being able to sort of add to shoring up the literature and the uses for the whole program, as well as for the screening tools, is this available for us to use in research as well? Is this something that we could use in research with proper credit, obviously referencing your work?
Absolutely, we would encourage that. There are, many opportunities, I think, to apply the materials, both clinically and in a research sense. So we're more than happy for that to be used in either or both settings.
Excellent. And I guess I just had one final question. I'm just going to double check. Nobody else has got anything up on the chat. with the sensitivity and specificity, particularly around the tools with the beat and the ACE, did you find any differences across different substances? Was there any differing sensitivity or specificity depending on the primary substance of concern that participants in the validation were using?
We haven't done that analysis. The majority of our participants were polysubstance users, so it's questionable as to how helpful that analysis would be. But it may be something we look at down the track. We are looking at some post hoc analyses, breaking it down by substance use, not specifically about the beat overall score, but we did a short study that is being written up at the moment, where we looked at the delayed discounting item of the beat and whether or not that varied across methamphetamine and alcohol as primary substance of use. And I think we found marginal to no difference between those two groups.
Right. Okay. All right. Well, I just really want to thank you for your time today. I really want to thank you for making it a publicly available resource. That's not always the case. And I think if anyone on the call today, whether you're aware or not, that isn't always the case, that we can open source these kind of resources for our clients or research participants more broadly. So that's a really excellent aspect of your work, I think. And so I want to thank you for your time today with sharing all of that with us. I look forward to seeing its applicability across potentially some of the centers who are on the call today. I think that there's been rumors that perhaps you might be invited to come share some of this with clinicians at some of the sites who are on the calls today. So look out for Jamie next year, probably, I guess, because this year's winding down. There's been a quick reminder on the chat that next week is a public holiday in New South Wales, so we will not be holding the DARIA session then. So again, if everyone can just join me in thanking Jamie. And Jamie, we look forward to being able to talk to you again, and feel free to come back and share upcoming research with us as well.
Thanks
Thank
a
you
lot,
very
Lisa.
much.
Thank you.
Have a
Goodbye.
lovely afternoon, everyone.